Welcome to the Deep Dive. Today, we're tackling a really significant shift in cancer care. It's all tied to something we're seeing globally in aging population.
That's right. And the connection to cancer is, well, it's stark.
Yeah, there's this projection that by 2040, nearly 70% of all cancer diagnoses, they'll be in adults age 65 and older.
It's a huge number. And historically, figuring out the best treatment for older adults with cancer, it was often quite uncertain.
Right, based mainly on just their age, their chronological age, not really their overall health.
Exactly, which led to this kind of dangerous split. You had some frail older people getting treatments that were just too harsh.
Way too much for them.
And then you had other really quite robust older adults who were maybe denied potentially life-saving treatments just because of their birth date.
A perilous dichotomy, as some have called it.
Precisely. But now, thankfully, there's a really strong consensus building. Major players like ASCO, NCCN, COG, these are big oncology societies.
The main ones, really.
They're all strongly recommending something called Comprehensive Geriatric Assessment, or GA. They're saying it needs to be a core part, truly integral, to managing cancer in older adults.
So it's not just a nice to have anymore.
Not at all. It's a fundamental shift. It's about moving towards truly personalized medicine, looking at the whole picture of the patient.
Okay, and that's what we want to unpack today in this deep dive. Why this assessment, this GA, is so critical, what's actually in it, and how is it really changing things for the better, making sure treatment is about the person, not just fighting the disease.
Exactly.
All right, let's get into it. To really get why just looking at age isn't enough, maybe think about two 75-year-olds.
Okay.
One who's, I don't know, running marathons, super active.
Very fit, yeah.
And another, same age, maybe mostly homebound, juggling several chronic conditions, maybe some memory issues starting.
Vastly different situations.
Totally different. Same age on paper, but their health realities are worlds apart. It just shows the massive variety, the heterogeneity in the older adult population.
It's such a critical point, because the traditional ways we measured fitness for treatment, things like the Karnofsky score or the ECOG score,
The standard performance statuses.
right, they're useful. They tell you about daily activities, basically. Can the person care for themselves? But they have this big blind spot.
Which is?
They often miss these really crucial underlying vulnerabilities, things that truly predict how someone's going to handle the stress of treatment.
Okay, so overlooking those things, that can have pretty serious consequences, right?
Right.
What specifically are those traditional scores missing?
Well, a big one is functional reserve. Think of it like, how much resilience does someone have in the tank, physically and mentally, to bounce back from something tough like chemo?
Ah, okay. They're buffer zones, sort of.
Exactly. Yeah. They also often don't capture cognitive health well enough. Is there mild impairment? Issues with understanding complex instructions? That's huge for following a treatment plan.
Makes sense. What else?
Social support is another big one. Who's at home? Is there a caregiver? Can they get to appointments easily? And then nutritional status. Are they malnourished? This deeply impacts recovery and healing.
Wow. Okay, so things like stamina, thinking clearly, support systems, nutrition, these are all massive factors in whether someone can actually tolerate tough cancer treatment.
Absolutely powerful determinants, things that chronological age alone just doesn't tell you.
So, faced with these limitations, the answer that's really gaining ground, becoming the standard, that's this Comprehensive Geriatric Assessment, the GA.
That's the one. It's designed specifically to fill that gap, to give, as you said, a holistic portrait. It moves beyond the tumor, as the saying goes, to understand the host.
Beyond the tumor to the host. I like that.
And it's not just one test. It's usually a multidimensional process, often involves different specialists and interdisciplinary approach.
Okay.
And it digs into all those areas we just talked about. Functional, medical, cognitive, psychosocial. It paints a much, much richer picture for the oncology team.
All right, let's get specific then. If you were undergoing a GA, what are the core things they'd be looking at? What information are they gathering?
Sure. It typically covers several key domains. First is functional status.
Like we talked about daily activities.
Exactly. Both activities of daily living or ADLs, basic stuff like bathing, dressing, getting around, and also instrumental activities of daily living, IADLs.
Which are more complex tasks.
Right. Things like managing money, handling medications, shopping, using the phone, things needed for independent living.
Got it. What's next?
Comorbidity. Basically, what other health conditions does the patient have? Diabetes, heart disease, lung issues, kidney problems. They quantify these.
Okay, tallying up the other diagnoses.
Then cognition. This involves screening for dementia, but also for delirium that's like acute confusion and even mild cognitive impairment, which can be subtle but still affect treatment.
Right, ability to understand and stick to the plan.
Crucial. Then nutritional status. Are they eating enough? Losing weight unintentionally? Malnutrition is a surprisingly common problem and really impacts outcomes.
Okay, nutrition. What else?
Psychological health. Screening for depression, anxiety. These are common, especially with a cancer diagnosis, and can affect coping and quality of life.
Makes sense.
Social support. What's their living situation? Do they live alone? Have family or friends helping out? Is there a main caregiver? This is vital for practical support.
Huge factor, yeah.
Polypharmacy. This is a big one. Reviewing all medications the patient is taking, prescriptions, over-the-counters, supplements.
Why is that so important?
To look for drugs that might be inappropriate for older adults. Check for potential drug interactions, especially with cancer therapies, and just simplify the regimen if possible. Too many meds can cause problems.
Okay, cleaning up the medicine cabinet, essentially.
In a way, yes. And finally, they assess for geriatric syndromes. These are common health conditions in older adults that don't fit neatly into disease categories. Things like frailty.
Frailty seems key here. What exactly is that?
It's basically a state of increased vulnerability. Reduced physical reserve, less ability to bounce back from stressors like illness or treatment. It's more than just being weak.
Okay. And other syndromes?
Things like history of falls, incontinence, sometimes vision or hearing impairment. These often cluster together and really impact overall function and risk.
Wow, that is definitely comprehensive. It sounds like it digs up a lot of details that might otherwise get missed.
That's exactly the point. It often uncovers these hidden vulnerabilities, things that weren't obvious from a quick check or standard performance status, maybe poor nutrition or mild cognitive issues or lack of support.
So the real value is quantifying, what did you call it? Biological age?
Yeah, biological age or perhaps physiological age. It gives a much better sense of their actual resilience and fitness for treatment than just the number of candles on their birthday cake.
This is where it gets really interesting for me. These aren't just good ideas anymore. You mentioned major oncology groups are back in this. It's becoming a standard.
Absolutely. The evidence has been building and the consensus is now really solid. You have to give a lot of credit to SIOG, the International Society of Geriatric Oncology.
They were the pioneers.
They really were. They've been advocating for GA in older cancer patients for years, laying the groundwork.
And then ASCO, the American Society of Clinical Oncology, they came out with a big guideline.
Yes, in 2018, that was a landmark moment. Their clinical practice guideline explicitly recommended GA for all patients aged 65 and older who were going to receive chemotherapy.
All of them, not just the obviously frail ones.
All of them. And coming from ASCO, which is, hugely influential globally, that sent a powerful message. It really set a new standard of care.
What benefits did ASCO specifically point to? Why did they make such a strong recommendation?
They highlighted several key things based on evidence. That GA findings can actually predict who is likely to experience severe chemotoxicity.
You can anticipate problems.
Exactly, which allows you to potentially modify the treatment plan, maybe adjust doses, choose a different regimen, or add supportive care before problems start. And they also noted it improves communication.
How so?
By having these detailed discussions prompted by the GA, it helps clarify the patient's goals of care. What's most important to them? Is it aggressive treatment at all costs or maintaining independence and quality of life?
Okay, so better prediction, tailored treatment, and clearer goals.
Precisely. And it wasn't just ASCO. The NCCN, the National Comprehensive Cancer Network, their guidelines are followed by almost everyone in the U.S.
Very widely used, yeah.
They've also integrated these principles. They even recommend specific quick screening tools like the G8 or VES13 questionnaire.
What are those for?
They're short screens, easy to use in a busy clinic. They help identify which older patients are most likely to have vulnerabilities and would benefit from the full GA. It's a way to triage.
Smart. So screen first, then do the deep dive if needs.
Right. And NCCN has woven these geriatric principles into their specific guidelines for treating common cancers like breast, colon, lung cancer. So oncologists are prompted to think about these factors right from the start.
So the message from all these major groups, Pelagio, ASCO, NCCN, is pretty clear then.
It's unified and undeniable. GA isn't just theoretical. It's a practical, evidence-based tool that demonstrably improves outcomes for older cancer patients.
Okay, let's bring it home for the listener. If you or someone you care about is over 65 and facing a cancer diagnosis, what does all this actually mean? How does having a GA potentially change the treatment journey?
Well, the benefits are really manifold, but let's break it down. First, it significantly refines treatment decision-making.
How so? Give me an example.
Okay, imagine someone looks pretty good on paper based on standard scores, maybe ECOG 0 or 1, seemingly fit.
Okay.
But the GA reveals maybe they have borderline nutritional status and very limited social support at home. That insight might lead the team to say, okay, maybe the most aggressive chemo isn't the best choice here.
Because the risks might outweigh the benefits given those other factors.
Exactly. They might opt for a slightly less intensive regimen and bring in a dietitian and a social worker right away for support.
Proactive support.
Yes. And conversely, you might have someone who's, say, 80 years old. Traditionally, they might have been steered away from standard treatment.
Just based on age.
Right. But the GA shows they're actually incredibly robust. Great functional status, good cognition, strong support. That assessment might give the team confidence to offer a standard, potentially curative therapy they otherwise wouldn't have considered.
So it truly personalizes the decision, cutting both ways, getting the right treatment intensity for that specific individual.
That's the goal. The second big impact is predicting and mitigating toxicity.
Preventing side effects, essentially.
Or at least lessening their severity. By identifying frailty or other vulnerabilities before treatment starts, you can put preemptive measures in place. Maybe starting physical therapy to build strength, getting nutritional supplements on board, planning for proactive dose adjustments if needed. It allows you to anticipate and manage side effects rather than just reacting when they happen.
And does that actually work? Does it reduce bad outcomes?
The evidence says yes. It can lead to fewer severe side effects, fewer hospitalizations, and interestingly, patients are often more likely to complete their planned treatment course.
Oh, that's interesting. So addressing these other issues helps them stick with the cancer treatment itself.
It seems so. By managing the whole person, you improve their ability to tolerate the specific cancer therapy, which, of course, impacts the chances of success.
Right. Better tolerance, better adherence, potentially better outcomes.
Makes sense.
And the third point.
The third key benefit is fostering truly patient-centered care.
How does the GA help with that?
The assessment process itself, by asking about function, priorities, quality of life, social situation, it naturally opens the door to deeper conversations.
Conversations that might not happen otherwise.
Often, yes. It prompts discussions about what matters most to the patient beyond just survival rates. What are their personal goals? What level of function do they want to maintain? What are their thoughts on end-of-life care, should it come to that?
So it ensures the treatment plan really aligns with the individual's values and priorities.
That's the aim, making sure the burdens of treatment don't outweigh the benefits from the patient's perspective.
Okay, the benefits seem really clear. Better decisions, less toxicity, more patient-centered care. But I imagine it's not always easy to just implement this everywhere. What are the hurdles?
You're right, there are definitely practical challenges. Time is a big one. Performing a full GA takes more time than standard assessments, and oncology clinics are incredibly busy.
Yeah, time pressure is always an issue.
There's also a shortage of healthcare professionals specifically trained in geriatrics who can conduct or interpret these assessments. Geriatricians are not always available in cancer centers.
So a workforce issue.
And finally, reimbursement can be a barrier. Getting paid adequately for the time and expertise involved in a comprehensive assessment isn't always straightforward in every healthcare system.
Okay, time, training, and money. The usual suspects, perhaps. So what's being done? Are there solutions emerging to make GA more feasible in the real world?
Yes, definitely. People are working on pragmatic solutions. We mentioned the rapid screening tools, the G8, VES13. Those help target the full GA to those who need it most, saving time.
The triage approach.
Right. There's also a big push to integrate GA components directly into electronic health records. Maybe using patient questionnaires filled out beforehand, embedding prompts for clinicians.
Streamlining the data collection.
Exactly, and training other members of the oncology team, specialized nurses, physician assistants, pharmacists to administer parts of the assessment, expanding the pool of people who can contribute.
Spreading the workload. Makes sense.
So while challenges remain, there's a lot of innovation happening to make this standard of care a practical reality.
It really does feel like this strong collective call from the world's leading oncology groups. It marks a truly pivotal moment, doesn't it? Moving past that old one-size-fits-all approach based on age.
I think it does. Integrating geriatric principles into cancer care isn't just a niche specialty anymore. It's becoming really a clinical and ethical imperative.
An ethical imperative, why?
Because we have the tools now to better understand the complexities of aging and cancer. Using them ensures that our treatment decisions optimize not just survival, but also quality of life, dignity, and the personal goals of this very large and growing group of patients.
It feels like a fundamental commitment then, to treat the whole person, not just the tumor marker or the scan result.
Absolutely.
It really makes you think, doesn't it? How all these different aspects of a person's life, their balance, their memory, who helps them at home, the pills they take, how all these seemingly small details, when you put them together, can completely change the best path forward for treating something as serious as cancer. It's a much more complete picture.
It truly is.